Good morning all. I'm Dr. Suhasini from Kokilaben Dhirubhai Ambani Hospital. I'm presenting a case of patient with sickle cell disease with complex congenital heart disease undergoing cardiopulmonary bypass, needle in the haystack. Sickle cell disease is a rare genetic disorder with a birth prevalence of 115 cases per 1 lakh live births. Pathophysiologically, it's a hemoglobinopathy caused by substitution of valine for glutamic acid at 6th position in the chain due to point mutation in the gene which codes for it. Hemoglobin S, when get deoxygenated, tends to polymerize, aggregates, and lead to vaso-occlusive crisis. Cardiopulmonary bypass associated with all triggering factors which can lead to profound sickle cell crisis and hence mandated specific precautions with management strategies to prevent fetal vaso-occlusive complications. A 4.6 years boy weighing 11 kg with height of 94 cm, body surface area of 0.5 meter square with a primary diagnosis of double outlet right ventricle with large subaortic VSD, status post VSD closure with subaortic membrane resection, and he is a diagnosed case of sickle cell disease. He presented to us with dyspnea on exertion of NYHA grade 2 but 2 to 3. In his detailed echocardiography, he has got a severe mitral stenosis with a mitral inflow obstruction due to supramitral ring with a small mitral annulus with single papillary muscle. He has got severe pulmonary hypertension with moderate tricuspid regurgitation. We attempted for the balloon mitral valvotomy, which was failed, and hence the patient was planned for redo surgery for supramitral ring excision. Preoperatively, he was on tablet hydroxyurea and tablet Folvit. Regarding his investigations, he was sickling test positive with hemoglobin S of 49.9%, which is quite high, with the hemoglobin level of 10 and the within normal organ function test and the coagulation profile. Challenges faced were as the CPB triggers profound sickling due to the inflammatory cascade, hypothermia, hypoperfusion, and acidosis, which would lead to vaso-occlusive crisis. Exchange transfusion was done to avoid sickling as HbS was more than 40%. The timing of exchange transfusion was important because preoperative exchange transfusion was posing significant risk as it's a severe mitral inflow obstruction. Any volume shifts were detrimental. Being a redo case, it would be extremely difficult to initiate CPB if any catastrophic changes in hemodynamics occur while doing exchange transfusion in preoperatively or doing it after induction of anesthesia but before the initiation of CPB. It was not advisable to expose the patient to the risk of general anesthesia only for the exchange transfusion. Preoperatively, patient was optimized with packed red blood cell transfusion. After multidisciplinary team meeting, decision was taken to perform intraoperative complete exchange transfusion just before the initiation of CPB with aortic and the venous cannula in situ in quick and controlled fashion. I would like to share our experience with exchange transfusion. So here we removed patient's blood volume gradually, which was containing ample amount of hemoglobin S from venous cannula, and equal amount of volume was replaced by a prime which was oxygenated and pre-washed via aortic cannula so to increase HbA level. Our prime fluid contained packed red blood cell units 8 units, fresh frozen plasma 3 units, 5% albumin, mannitol 100 ml, calcium, plasma light with adequate quantity of buffers, and it was heparinized with 400 units per kg heparin. During this procedure, patient had got hypotension up to systolic pressures falling down to 50 millimeters of mercury, and hence the procedure was halted temporarily, and the patient received volume through the aortic cannula in situ till the hemodynamics got stabilized. We did a serial monitoring of hemoglobin S during the procedure, and the initial value of 49.9% was dropped to 7.1% and then 6.5%. We modified our CPB technique as the circuit was modified with large capacity of venous reservoir, oxygenator with hemofilter, and we have set gentle occlusion for pump. We ask for bicable cannulation. We use hyperoxygenated prime solution. We used mild hypothermia. We used warm crystalloid cardioplegia for induction, followed by cold crystalloid cardioplegia for maintenance. We avoided hypoperfusion, hypoxia, and acidosis. We maintained adequate flows on the pump. The hematocrit was targeted for 24% and above. We did continuous ultrafiltration and modified ultrafiltration. And NIRS has got important role over here as we considered hemodynamic instability, and so monitoring of cerebral regional perfusion was quite essential. This was our charts. So you can see we maintained the pH of 7.4 to 7.3. The hemoglobin was also maintained adequately, and so the gaseous exchange also. We can see the hemoglobin S levels. Patient had got single uneventful cardiopulmonary bypass of 172 minutes with cross-clamp time of 68 minutes. Uneventful recovery with no vaso-occlusive crisis and got discharged on post-op day 15th. So patient with sickle cell anemia, hemoglobin S level more than 40%. Exchange transfusion is though mandatory, can be done safely intraoperatively in quick and controlled fashion. Strict no for hypoxia, acidosis and hypothermia. Use warm cardioplasia and maintain optimal blood gases. Serial check for the HbS level. Counseling is very important in this scenario. Thank you.
Thank you, Suhasini.